Anticonvulsants are an important chapter for which literally side effects are going to really drive you nuts. Since there is very little rhyme or logic into the side effects, a lot of them having to do with immune type of responses, which are non-dose related, and yet they are very relevant. The anticonvulsants and their mechanism of action is primarily based on what we know currently about seizures. Seizures are really spontaneous depolarization of neural tissue. These depolarization we're talking about can be part of a known etiology, such as having meningitis, increased intracerebral pressure, maybe because of a tumor, think of meningiomas for instance, or maybe simply because of fever, hyperammonemia, or certain toxins. In cases where we know the cause, then of course the use of an anticonvulsant medication would be a single use or a short-term use, and this is not our purpose in this chapter. Our idea here is to look at the patient who unfortunately suffers from idiopathic or essential epilepsy. In that situation, we have there a population of patients who will be using anticonvulsants potentially for decades, if not for a lifetime. This is under these conditions that side effects, drug interaction become extremely relevant. As far as mechanism of action, if I want to interfere with electrical activity, I would like to be able to interfere with action potential generation or conduction. To decrease axonal conduction of action potentials, we really want to use drugs that are similar to our antiarrhythmics of the cardiac section. And primarily because an action potential in the CNS is associated with sodium entry and hyperpolarization with potassium exit, so sodium coming in for the phase of ascent, potassium leaving for the descent, you might think, well then I know I'm going to use either a class 1, a sodium channel blocker, or a class 3, a potassium channel blocker. You are absolutely correct. And if you remember well, maybe the least toxic of these drugs would be a class 1b drug. Drugs like lidocaine, since they recognize inactivated sodium channels, which are found primarily in depolarized tissues, which are characteristic of epilepsy. Now, I cannot use lidocaine, of course. This was a drug that could only be used parenterally because of first-pass metabolism. I need to use lipid-soluble, orally administered type of medication. Carbamazepine and phenytoin are the primary anticonvulsants for the past 50 years, and as such they are actually class 1b medication. They work on the inactivated sodium channel. They will not prevent the detonation of a seizure, the starting of the seizure. They'll let the action potential initiate, but then they'll prevent the conduction by trapping the ion channels in their refractory state. The other possibility is that of our chapter 1 of the CNS section, to enhance inhibitory tone through hyperpolarization. Hyperpolarization can easily be achieved through GABA-mediated effect of drugs such as barbiturates and benzodiazepines. Let's not forget that these are drugs that are used in status epilepticus, for instance. Newer modalities have explored the effect of glutamate. Since glutamate is excitatory, the idea would be to use drugs that decrease the excitatory effect of glutamic acid. These newer drugs have failed to prove themselves as better than the conventional phenytoin, carbamazepine type of medication. As such, they kind of backup drugs for most seizure states and are not quite as relevant on your exam as looking at drugs like carbamazepine, phenytoin, or valproic acid. So here we mention medications such as lamotrigine, topiramate, or felbamate, and if you have room in your brain, why not remember these three? Glutamic acid pharmacology is fairly complex, involving several subtypes of receptors. One major receptor to commit to memory, we'll talk about it with the drug ketamine later on, is the NMDA receptor. Felbamate is an antagonist of these receptors. Another subtype of receptor is AMPA, and topiramate, for instance, blocks these AMPA receptor. So decreasing excitatory effect of glutamate is another avenue in managing seizures. The final mechanism of action of seizure medication would be to decrease the entry of calcium through T-type calcium channel. So should you think of drugs here like verapamil, diltiazem, or nifedipine? If you are, you're making a mistake, since those drugs were working on L-type calcium channel, and here we are talking a T-type calcium channel. These are channels that are very abundant in neurons of the thalamus being our sensory and motor relay. And as a sensory motor relay, it has been very much implicated in absence type of seizures. You know, the classic stem of an absence seizure is the exact presentation of the pathology. A child at school suddenly staring blank and dropping his or her pen. Absence seizures seem to be a moment whereby the brain is totally unplugged from sensory information from the environment. And if this is the case, we have always thought that maybe the thalamus would be the locus where the seizure starts. T-type of calcium channels being abundant there, a drug that blocks these T-type channel can interfere with the activity of neurons in the thalamus, and ethosuximide is a drug that is literally uniquely used in absence seizure because of its pharmacology of blocking T-type channels. Now, notice that valproic acid could be part of this group too, but as we fix to see, valproate or valproic acid can be really placed in most of the classes or most of the mechanisms of action on this page. Before we see the drugs one at a time, well, let's talk a little bit about seizure types. There are broadly two types of seizures. What we call a partial seizure is involving only a small section of the cortex and can present in a number of ways depending on which neurological center is affected by the depolarization. A seizure that we call generalized is one that involves most of the brain tissue. And in generalized type of seizure, two dramatically opposite types. The tonic-clonic seizures are the classic grand mal, French for big disease if you want, and grand mal seizures are characterized by a big component of motor activity. First some thrashing of arms and legs, and then some hypertonic contraction of the muscle. In all situations, generalized seizures are associated with a loss of consciousness. We've already described absence seizures as being primarily a moment of CNS depression, if you wish. Well, here is something about drug management that is quite relevant. Whereas valproic acid, phenytoin, carbamazepine, barbiturates, benzodiazepine could be used for any type of seizures, when it comes to absence, most of these drugs would be expected to exacerbate, worsen an absence seizure patient because these drugs are strong CNS depressant. That's why you truly can think of ethosuximide as a drug of choice, a DOC in absence seizure. How come valproate could be used in absence? Well, this is something we will answer shortly. But before we leave this table, let's not forget status epilepticus, those life-threatening seizures that do not abate over a period of a half hour or so. Basically, if you want, at the histological level, depolarization of neurons, if it's too prolonged, will result in significant hydropic swelling from the accumulation of intracellular sodium and possibility of irreversible neurological damage. That is without adding the point that with status epilepticus, there's also some breathing compromise from the seizure activity. Well, for this, we need IV benzodiazepines such as lorazepam and diazepam, these drugs that increase the frequency of opening of the GABA-A receptor. There is potential of use of IV formulation of phenytoin, such as phosphenytoin, which is more water-soluble than phenytoin itself and better for its kinetic. We will look then at three primary drugs: phenytoin, carbamazepine, and valproic acid. Phenytoin is working through the blockade of sodium channels in their inactivated states. The inactivated state being the one, if you remember well, that was represented this way. M gate was open because of depolarization, and H gate was closed because of prolonged depolarization. Blocking these channels, if you remember in our fundamental concepts of arrhythmia, would delay the recycling of these channels back to resting, so would maintain the tissue refractory. As such, drugs like phenytoin are said to prevent not seizure initiation, but seizure propagation. Well, the use of phenytoin is only for seizure states, and if I were you, I would add the actual little comment that it's for any seizure states except absent seizure. That is because the CNS depressant effect of the drug phenytoin would exacerbate that type of seizure. Okay, in some cases, phenytoin has also been used as an antiarrhythmic for digoxin toxicity, but this is so minor as certainly not to be as relevant of what we just said here. Seizure states except absence. Its pharmacokinetic is the first point you'll find board question. If I go rather than in order of the pharmacokinetic phases, in order of importance, let's first remind ourselves this is a famous general inducer of P450. So that similarly to a barbiturate, it would be contraindicated in porphyria and enter a multitude of drug interactions. Let's then further recall that in the general principles, high therapeutic doses of phenytoin could be board tested as an example of zero-order kinetic of elimination. Do you remember the modality of zero-order elimination? This is a situation where you would have a constant amount of drug eliminated per unit of time. So the only thing we still have to work on are the first two statements. The fact that there is variable absorption to phenytoin with a nonlinear kinetic. Well, here's the deal. It stems from the zero-order kinetic of elimination. And I'm afraid that if we had added this already in the general principles, you would have overdosed so bad that you would have probably ended up in a poison control center. So let's do it right now. I'm going to take another page to explain to you one aspect of zero-order kinetic of elimination. Imagine these numbers. Imagine I am losing 10 milligrams of drug per hour. So a constant amount per unit of time, what we call zero-order kinetic of elimination. If I gave this patient 20 milligrams as a dose, then in 1 hour, 50% of the drug is removed, 10 milligrams being half of 20 milligrams. On the other hand, if I gave this patient 100 milligrams, well, and I'm using fake numbers, and don't imagine these would be correct doses for phenytoin. I'm just trying to illustrate the pharmacokinetics, so bear with me. At 100 milligram dosage, 10 milligrams per hour means in 1 hour I've lost only 10% of the drug. Now try it at 1,000 milligrams. 10 milligrams would now only represent 1%, and so forth. Notice that then the fraction or the percentage removed decreases with increasing dosage. If that's the case, let's try and imagine a curve representing absorption. All of us should be able to remember that if I put dose as a function of concentration, I would expect a linear relationship between increasing the dose and the concentrations measured in the blood. That is, if I double the dose, I should double the concentration. If I triple the dose, I should triple the concentration. This is based on first-order kinetic and a constant fraction of drug being removed per unit of time. It would be represented as a curve that would bisect these axes and show you that relationship. It came literally from the fact that a concentration is always a dose over a volume. And if the volume of distribution is a constant in a patient, then if you double the dose, you would obviously double the concentration. Fine. What would zero-order kinetic do? Well, imagine as I increase the dose, as shown above, you get less and less of the drug being removed as a fraction simply because you're working in zero-order kinetic. Well, it would mean the curve would have this look. As I increase the dose, the amount of drug piling up would increase much faster than expected, simply because I constantly remove only a number of milligrams from the actual administered dose. Well, this is what we call a non-linear kinetic of absorption. And that non-linear kinetic of absorption, or that variable kinetic, has clinical relevance. How quickly do you think you would reach toxic levels in a patient simply by increasing the dose? Should it be faster or slower than expected? With a curve that has the shape of the red curve here, that exponential increase in concentration as I increase the dose should make me reach concentrations that are toxic sooner than later. In effect, a nonlinear kinetic of absorption lowers the therapeutic index or the therapeutic window of the medication. So, as such, a point to remember is that toxicity to phenytoin, side effects of phenytoin are quite likely. Primary side effect, that of CNS depression. I'm decreasing electrical activity of brain tissue. I see significant CNS depression. At the very least, drowsiness, sedation. But you know, from the first chapter we worked on in the CNS section, this sedation, drowsiness is dose dependent, and the more I take the drug, the more likely I'm going closer and closer to respiratory depression and death. So a pretty toxic drug indeed. Then there are two side effects which we're going to highlight a different color because they are really unique to phenytoin. And if they're unique to phenytoin, then I'm going to think that if I see gingival hyperplasia and hirsutism, invariably I'm being tested on the drug phenytoin on the exam. Now, hirsutism is more of a cosmetic issue than anything else. I doubt this would be any deadly unless you stepped on your hair and fell down the steps. Gingival hyperplasia, on the other hand, remember, just as with nifedipine, we do have an issue with this. The potential for gingivitis, gum problems that could result in infections, which down the road could possibly cause septicemia or infectious endocarditis. Any drug with gingival hyperplasia would require a warning and a good follow-up by dentist or dental hygienist. Well, contrast. Side effects such as osteomalacia, megaloblastic anemia, aplastic anemia. These are certainly not unique to the drug phenytoin in that section. As a matter of fact, all the anticonvulsants will share those type of pharmacologies. The osteomalacia in adult or rickets in children comes from a decreased absorption of vitamin D and also a decreased activation of the drug. Remember, this is a drug that requires hydroxylation in order to be working. And phenytoin is pretty much using those hydroxylases in its own metabolism. So as such, vitamin D will be less activated and significant hypocalcemia would ensue. It can also mean, on the other hand, that the patient would start having secondary hyperparathyroidism and now develop hypercalcemia. So hypo or hyper, it all depends on your patient. All you know is that you're going to end up with calcium dyscrasias, also phosphate dyscrasias, of course. The megaloblastic anemia comes from uniquely a decreased GI absorption. Drugs like phenytoin, but also carbamazepine and barbiturates, actually inhibit GI conjugases. And GI conjugases are enzymes of the gut epithelium that are requisites in order to allow absorption of dietary vitamins. So as such, the folate deficiency could not only be associated with megaloblastic anemia in the patient, but also imagine this was a pregnant lady, certainly some teratogenicity. Now, notice that for phenytoin, we do not describe so much neurotube defects as would be expected from folate deficiency. But nonetheless, a link that allows you to remember that teratogenicity is a concern of anticonvulsant at large, and phenytoin in particular. Phenytoin is quite classic for resulting in cleft lip and cleft palate in the little babies. How about the aplastic anemia issue? Aplastic anemia is the hematological toxicity of so many drugs that behave as hapten. This is a hypersensitivity reaction, an immune response associated with the high protein binding of phenytoin on plasma proteins. Plasma proteins that could be associated with cells can now be opsonized and destroyed. In the aplastic anemia, always worry about the drop in white blood cells with the potential for overwhelming infections. Well, just like we saw with drugs such as procainamide in the cardiac section, with drugs like hydralazine, any drug that can cause this type of immune dyscrasia would result in a need to do regular complete blood cell counts and monitor at least on a 6-month basis and thereafter on a yearly basis that our patient does not develop some significant drop in white blood cells. This is the baseline drug, the drug phenytoin, and all its detrimental side effects. As you go on and review the drug carbamazepine, you must now compare carbamazepine so that you can highlight for your exam questions what are similarities and what are differences between these two drugs. Surely, at the level of mechanism of action, there are absolutely no differences whatsoever. For instance, carbamazepine is again a voltage-dependent sodium channel blocker that will interfere primarily with the inactivated form of that channel. It is also used in any seizure states, you would tell me, except absence. And besides that, has one unique use that you need to highlight differently, a use that we did not see for phenytoin. It is the drug of choice in neuropathic pain such as trigeminal neuralgia. You know, I always have a lot of sarcasm with the way medically we interfere with pain or try and treat pain in patients. Basically, I always think of it this way. We can't really go ahead and use a hammer and just hit the patient's head so that they stop complaining about pain. It is considered unethical. And as such, rather than doing so, we use chemicals to do exactly the same thing. In a way, if we cause significant CNS depression, the pain complaint and the pain perception might be totally dulled because of the CNS depressant effect of a medication. Carbamazepine has very much been used for trigeminal neuralgias, and as such is a use that is not shared by phenytoin that you should remember well for your exam. Other drugs are used in neuropathic pain, such as amitriptyline that we'll see as a TCA, for instance. The beta blockers can be used in neuropathic pain too because of their CNS depressant effects, such as the drug propranolol. So it's only one of several, but it's the drug of choice. Carbamazepine has also been used in particularly the manic phase of bipolar disease. So although lithium there will be the drug of choice, carbamazepine has other FDA uses besides seizures. In its pharmacokinetic, it has the same problem as phenytoin when it comes to metabolism. It induces P450s. As a matter of fact, it induces even its own metabolism, possibly requiring higher doses as you go along treating the patient chronically with the drug carbamazepine. These higher doses are bound to be associated with side effects. And if the primary side effect is CNS depression, certainly osteomalacia and megaloblastic anemia from vitamin D and folate disturbances respectively are classic. So are the aplastic anemias that we explained already for the drug phenytoin. Well, maybe then what you would like to highlight is the fact that there are two unique side effects also, or more likely side effects of carbamazepine. In the hypersensitivity reaction, the potential for rashes, including Stevens-Johnson syndrome, also known as exfoliative dermatitis. Although I bet you that on your exam you're more likely to be tested with sulfonamides for such a hypersensitivity reaction, there is no doubt that a number of CNS drugs can cause also that life-threatening condition. But maybe more importantly, carbamazepine is one of these odd drugs that can cause your pituitary to produce more ADH. This is an observation of several CNS medication, antipsychotics, antidepressants, anticonvulsants. For some reasons unknown to science to date, they can actually increase ADH. This increased ADH would invariably result in retention of free water and dilutional hyponatremia. As such, let's not forget that then edema would result, and in the CNS, edema would result in increased intracranial pressure and the potential for herniation. This is a side effect that would be expected of very high dose carbamazepine, or maybe an overdose situation such as mom and dad wanting to increase the carbamazepine dosage in their child simply because the child has an escape seizure, possibly increasing the dose from the point that carbamazepine has induced its own metabolism. So a risk and a side effect pretty unique that we want to know well here. The teratogenicity is fairly classic, with not only the cleft lip and palate in the findings just like phenytoin, but also the spina bifida that would be expected from the link to folate deficiencies. Our third primary anticonvulsant is the drug valproic acid. And as I'm looking at valproic acid, I'm looking at a drug that has a number of differences compared to phenytoin and carbamazepine. Surely I could ask you about sodium channel blockade. Valproic acid does the same thing as phenytoin and carbamazepine, classically blocking the inactivated state of that sodium channel, preventing propagation of the seizures. But what is really most important of valproic acid in its mechanism of action on board question is the inhibition of the enzyme GABA transaminase. Understand GABA transaminase as a degradative enzyme of the neurotransmitter GABA. This is an enzyme that would take GABA and make it inactive metabolites. So if I block GABA transaminase, valproic acid can then result in an increased level of the neurotransmitter GABA. GABA being inhibitory, there would be a great CNS depressant effect through that mechanism. If you want, in a way, it's a little bit like having a benzo or barbiturate on board at the same time as you would have a phenytoin or carbamazepine on board. Although valproate does not bind to the GABA-A channel like benzos and barbiturates do, it certainly influences GABA responses. If that wasn't enough, valproic acid is also known to block the T-type calcium channels in the thalamus. This is why, when in the use, it says seizure states. This time, you can actually say including absent seizures. So unlike the other two, the indications really cover any type of seizure. This is a drug that is also used in the manic phase of bipolar disease, that is like carbamazepine. It's also a drug that is used in neurogenic pain, including that of migraine headaches. So quite a similarity in the potential uses between valproate and carbamazepine here. Now here's a big difference. When you look at the effect on cytochrome P450, remember that whereas barbiturates, phenytoin, and carbamazepine induce these enzymes, this is actually a chemical that inhibits cytochrome P450s. So as such, rather than speeding up metabolism of other medication, this one would slow them down and cause a buildup of other chemical. Notice that the side effects of valproic acid are different than the profile we've established for carbamazepine and phenytoin. It is hepatotoxic from a toxic metabolite, and it will require monitoring of complete blood cell count, primarily because of a potential destruction of platelets rather than white blood cell. But really, one side effect that from feedback has often been tested is that of pancreatitis. Albeit it's certainly not the primary drug to be associated with pancreatitis. Your board likes it, I think, because the pathologists like it. Pathologists have known valproic acid as a cause of pancreatitis for just about a century. This is how old the use of valproic acid is, literally since about the 1910s. So as such, make sure you remember pancreatitis. But really, alcohol and certain HIV medication blocking reverse transcriptase are certainly more relevant than pancreatitis induced by valproic acid. If alcohol is not a prescription drug, drugs like didanosine and drugs like zalcitabine have been associated with potentially life-threatening and certainly dose-limiting pancreatic toxicity. So I would like you to add this as a little note in your margin so that you familiarize yourself with some relevant board drugs for pancreatitis. If you want to really put icing on the cake, another one I've actually heard about is asparaginase. When it is board tested, asparaginase is actually a drug used in leukemias, used in cancers. It is also a drug associated with pancreatitis. Alopecia, otherwise, is also to be highlighted for your board step 1. I know losing hairs compared to having a pancreatitis that could be life-threatening seems so stupid to have to remember. Yet, imagine the little game for your exam. What drug was causing hirsutism? Absolutely, the drug phenytoin. So now you have a drug, valproic acid, that causes the opposite. You lose your hair. I don't know if the board's point is that you choose your drug based on the hairdo you want to achieve, but certainly it does give you a point to actually recognize the two drugs. So remember alopecia with valproate. As you lose hair with valproate, by the way, those of you interested in changing your hairstyle, it causes a frizzy, kinky type of hair. Teratogenicity is also the rule. So now your three primary anticonvulsants are associated with the possibility of fetal damage that would show here as primarily spina bifida. So review with me. Phenytoin was cleft lip and cleft palate. Valproate is associated with spina bifida. How about carbamazepine? Well, sitting in the middle, it does both, cleft lip, cleft palate, and spina bifida. Which brings about then, ultimately, what are we going to have to do in situations of pregnancy? Now, ethosuximide. All you need to know on your exam is that it blocks the T-type calcium channel and is only used as a drug of choice for absent seizures. In the general features, let's make sure that all anticonvulsants are CNS depressant, therefore they are additive with other CNS depressants such as alcohol, benzodiazepines, barbiturates, opiates, antihistamine, etc. Abrupt withdrawal invariably would result in status epilepticus. Your patient must be aware that they must keep on board their anticonvulsants. There is no such thing as, oh, I forgot my drug this weekend while going camping. It's fine, I've taken it for the past 10 years. I'll take double the dose on Monday. As soon as withdrawal would settle in, there would be life-threatening potential for status epilepticus. Then there's the issue of that teratogenicity we were just mentioning. You can imagine that most ladies will then opt for oral contraception in order to avoid an unwanted pregnancy with a risk of teratogenicity. Here's the issue. Inducers of cytochrome P450s will decrease the efficacy of oral contraceptive pill by speeding up their metabolism. Well, can you tell me actually what would be a drug that does not induce P450? You are correct, valproic acid. So if you wanted to avoid that drug interaction in order to maintain the adequate efficacy of oral contraception, possibly valproate would be a better choice. How about the counterpart? This lady wants to be a mom and wants to become pregnant. What should I do? Then I need to choose the least teratogenic of these drugs. Remember that choices in pregnancy are that of drugs that have higher plasma protein binding, so that less of a free fraction could cross the placental barrier and affect the fetus. In the anticonvulsant, phenobarbital is considered the safest during pregnancy based on its high plasma protein binding. It makes this old drug still quite a board relevant and clinically relevant medication under these circumstances. As to the other anticonvulsant drugs, when we put other in your book, we really mean if you're very comfortable with the previous drugs, then by all means go ahead and know more. If you're really not, then these drugs are so much less likely to be board tested that you could avoid them if you wanted to. Felbamate, lamotrigine are glutamate receptor antagonists. They also block sodium channels like phenytoin and carbamazepine. When they are used in seizure states, they're primarily used as adjunct therapy. Well, their primary side effects is the main reason why they have not supplanted the use of phenytoin and carbamazepine. Look, aplastic anemia, therefore non-dose related immune responses, are classic for felbamate. They even have a warning associated with them, these drugs. For lamotrigine, the primary issue is hypersensitivity reaction involving life-threatening dermatitis, such as Stevens-Johnson syndrome. Add to this that both drugs are significantly hepatotoxic. There is no wonder why they have not replaced the primary anticonvulsants. As to newer drugs such as GABA drug, you hear GABA in their name, such as gabapentin. This is a drug that enhances GABA effect without really binding to the channel. It is used in seizure states and neuropathic pain, and an advantage of GABA drug is certainly that aplastic anemia and liver failure are both rare. But you know the story. Sedation is going to be the primary side effect of any GABA medication. This concludes Chapter 3 on anticonvulsants.